Hello. So my name is Brad Mullin. I'm a neurosurgeon. I work at the Mount Carmel Health Systems in Columbus, Ohio. And I've used the Body Tom intraoperatively since 2014. And today I want to speak mostly about my uses in spine surgery and disclosures. I do act as a consultant for Stryker, and I'm doing this under a consultant agreement from Neurologica. I really want to speak about the use of intraoperative CT along with navigation. I think marrying the two really gives you the most advantage to the use of the intraoperative CT. I would like to compare and contrast the intraoperative CT, the Body Tom, with other types of units really that are more like 3D fluoro units as such, and tell you some of the advantages of the Body Tom. So the real advantage of the Body Tom is that it is truly a full CT. And if you want to image the spine in more of a global sense so that you can see things like spinal alignment, you can image the full pelvis all in one field of view, so you can navigate, say, to put in pelvic screws or put in S2 alar iliac screws. It really is the Body Tom that you really need to utilize. And since really complex spine surgery is moving more and more to discussions of alignment like sagittal balance and coronal balance, etc., being able to see the spine in a longer segment is really useful. I've given a lot of talks about radiation reduction to staff and surgeons, and I think this is an important use of intraoperative CT combined with navigation, and we'll detail that in a minute. There are a lot of reasons that the Body Tom is a real advantage in terms of seeing the spine in areas where it's often difficult to image. For example, the cervicothoracic junction, high BMI patients. And if you use a 3D fluoro type of system, you'll see that there's ghosting, seeing cortical margins to understand, say, a thread penetration. Those types of things are much more difficult unless you're actually looking at a CAT scan. There are times in which you like to visualize non-spinal anatomies. So for example, if you're operating and you're concerned about an anterior breach and unfortunately potential injury to vascular structures in front of the spine, you have at your disposal a full CT that will actually see the detail. There are a lot of intraoperative decisions that you can make when you have a full CAT scanner. For example, if you're going to connect to a previous fusion construct, you can see what's fused, what's not fused, or sometimes you'll make decisions on the fly about whether or not a level needs to have an interbody device or not, based upon whether or not you can actually see that it's fused as you're working. It's really useful for use in distorted anatomy. There are times in which unexpectedly you'll find pedicle in an odd position, pedicle that's not really being able to accept a screw, and it's really nice to see that in real time. I've learned to, I think, do what's called reading the bone structure. So for example, when you're placing a screw, and the sacrum's a good example of this, there'll be areas of higher density and lower density. And if you want to prevent lucencies with time, you can actually shoot for the areas of stronger bone. I've used it a little bit in cranial applications, and Dr. Wernicke will speak more about this, after a pituitary resection to verify that you actually brought mass down off the chiasm. I like to, after I do a stereotactic biopsy, to run a Body Tom to look for a bleed before I leave the OR. In spine surgery, a real goal is to reduce takebacks to the OR, say if the hardware is malplaced, and at least a spin of the scanner before you leave the OR should prevent that. And it's very useful for use in MIS surgery, specifically with a spine mask. It's how I use it. That's a Stryker product. And there are other types of products that you can use, but it works very nicely with the spine mask, and we'll show an example of that here in a moment. So in terms of radiation exposure, there are many studies out there which detail that when you're using fluoroscopy in surgery, there really is a lot of exposure to radiation, not only to the surgeon, but to everybody around that table. And if you start to add up the amounts of exposure, it's remarkable. And if you then take that over a 30-year career, if you are putting these pedicle screws in under live fluoroscopy, you're going to get a great deal of exposure. And this is a study from 2013 that shows the milligram exposure per minute of everybody around that table. This is a study in 2010 which showed that, and I believe that we've attained this too, essentially zero exposure to the surgeon and operating staff because we actually leave the room. And as part of what our physicists have done is they've measured any exposure even outside of the room, and we're at zero. So if you use this in combination with navigation, you should be able to bring your exposure down to a very minimal amount. And just to kind of compare to what milligrams mean, a chest X-ray is about 10. In other words, if you are using the fluoro continuously, you may be talking about a couple of chest X-rays a day. I know we wear lead, but very few people I know wear leaded glasses, and the exposure to the lens gives you a risk of cataracts, and that risk is linear over years of exposure. Navigation in combination with intraoperative imaging gives you superior accuracy. Here's 3 studies that demonstrate that accuracy is much higher when you use computer-aided navigation. And at times, misplacements, although they're not always significant and may or may not hurt the construct, there are patients who are injured by malplaced devices. And as we mentioned, taking back a patient to move a screw, of course, is yet another surgery with the risks of anesthesia. And estimated costs of a take back is about $60,000. And it's conceivable that at times that insurers may not pay for those take backs for that purpose. So some of the things 3-dimensional navigation can overcome. You do a lot of spine surgery, you'll note, there's a lot of variability in between patients and shapes of the vertebral body and the pedicles. Obesity, as you know, with fluoro, sometimes you just flat out can't see. Osteoporosis and trying to find stronger bone. It's really useful in scoliosis and kyphosis where nothing is in a normal plane. We talked a little bit about radiation exposure, and obviously we're trying to avoid any injury to other structures. So I call this the little shop of horrors. These are not my cases, but people walk into your office with these malplacements, and at times they can be quite catastrophic, with the aorta, for example, being very close to it in a thoracic screw placement. So this is obviously what we're trying to avoid. At least a scan before you leave the OR should help you avoid this situation. When you use the body tom, there it's extraordinarily important that you develop a workflow and that everybody in the room, all the staff, becomes very proficient in understanding the flow from all the way from the positioning of the patient all the way through the taking of the scan. And so, for example, we have open and MIS workflows. The table is very good in terms of trying to induce lordosis in the spine, which is, of course, a goal. When we are navigating, I always place screws first before I do a decompression, because the decompression loosens the spinal structure and changes the accuracy. With MIS, it's very useful because we scan the patient before we even open, so we're able to use navigation to direct our approach and minimize our exposure. So these are some images that we took to show first of all, the arm boards, so that initially when we got the body tom, the table was turned so that the head was away from anesthesia. They didn't like that very much, so very quickly we went to an extension so that anesthesia got the head back. And then there are arm boards and positioning of the arm boards are very important. If we're going to L2, above L2, we'll tuck the arms. If we're going below L2, we'll use the arm boards. But we always do a trial run before we do any draping. just to make certain that the patient is positioned appropriately for the run. Table height is extraordinarily important, part of the positioning, to make certain that once we know exactly what position the patient has to be in to run the body tom, that we can just position the patient. So this shows the table where we've actually selected the height, and then we'll use a marker, erasable marker, to show exactly where it has to be so that there's no mistake in the positioning. Draping, we've gone to using a fluoroscopy drape, basically, which is quite cheap and enables you to actually see the patient, see the wound, and when you're running the body tom. In open cases, I like very much to use fiducial screws. It adds the greatest accuracy to the scan, and so it's very common for us to have sub-millimeter accuracy when we're actually doing our navigation. So shows the fiducial screws. We just use CMF screws, little cranial plating screws, and we select them and feed them into the navigation system, and then select them as known points. I call the running the body tom a spin. This should show a spin. You can see the patient is positioned, the table height was selected, the patient's draped, and then we'll run this in position. And then the body tom will give you a scout run, and then you can actually leave the room for the scout. I walk in and check the scout to make certain that everything is seen on the scout, and then we actually run the spin. So this is just coming in position for that. One consideration when you're doing intraoperative imaging and navigation is the consideration that maybe it takes too long and you're adding to the case. Here's our timing. So I always do a first scan to do my navigation, then a confirmatory scan. So this is actually times I'm away from the table, 15 minutes for the first scan and 7 minutes for the confirmatory scan. So that amount of time added to the case to me is definitely worth the benefits. This shows you the spine mask and how it's used. So it sticks to the patient and has both the basically the fiducials and the transmitters in place. And then this shows a body tom scout where it's I don't know if you can see it, but there are little fiducials you can see. And so as you can see, when you run the body tom, you can basically scan as much or as little as you want of the spine. As we get into more and more percutaneous screws, obviously the body tom is very useful. Not my picture, but as you can imagine, they've shown that with percutaneous screws and you use the fluoroscopy like this, the amount of radiation is even higher than those other data that I showed you. The structure visualization is really quite superior between the body tom and the O-arm. Not only the cortical margin, but also the adjacent structures are very well visualized, as we talked about, the risk of perhaps a retroperitoneal bleed. I think it's very, very good for placing screws into the pelvis. Because of the field of view, you can actually see the entire pelvis, so you don't need to take multiple images. And if you can appreciate, as you're crossing the SI joint, there's different areas that have more or less density that you may want to try and pierce with your screws. So it's very good at doing screws like this. Here's a case where we wanted to know that for sure that we were fused at 4-5 to connect. And then this is an example of this looking at the sacrum, where you'll have different densities of bone, and the promontory here where you want to shoot to anchor your screw if at all possible. We do all of our screw sizing basically on the fly. So we'll do a virtual screw and see what we think about it in relation to the pedicle, trying to use the diameter of the pedicle to its greatest extent. When we place interbody devices, we do a virtual interbody device and look at the placement and the sizing. So again, we're not doing any of this under fluoroscopy. As we talked, screw visualization with the body tom is really superior. You can actually visualize the cortical margins when you're looking for a breach. And obviously, with very, very important structures very close, then accuracy becomes paramount. Spinal balance, as we work on things like sagittal balance, you can scan as much as you want, and then in your confirmatory scan, you can actually look and see how well you did your correction. This is an example of what was a very difficult case. This was a C12 disarticulation from a car accident. Basically, the patient pulled C1 off of C2. We actually tried to do this patient, and once we positioned them, they lost their signals from monitoring. So we put them in a halo and then did it again. So we did our Bonnie Tom work actually in a halo. You can see all the apparatus that we had to use to try and position this patient, but it went very well. We ultimately got a nice occipital cervical structure with the use of the Bonnie Tom and navigation. High BMI is very difficult at times, as you can imagine. This was a huge BMI patient, and this is the hula hoop test. I actually have one of these in my office that I use to make certain that the gantry will work on a given patient. You can say, well, that looks a little degraded, but this is that same patient, and doing this under fluoroscopy I would say, was probably pretty much impossible. So thank you. If there's any questions.
How long did it take you to establish your workflow? Also, can you scale down the dosage for smaller constructs?
I would say it's probably a 20 case learning curve, especially you want to try and have constant staff if you can, because everybody gets used to it. And absolutely, you can scan as short a segment or as long a segment as you want, and the dosage comes from the number of segments scanned.